Constipation represents one of the most serious adverse effects of clozapine, and every clinician really needs to become expert in managing this. The rate of constipation is very high, up to 60% incidence reported, and for ileus, the rate is up to 1.3%, and it is sometimes fatal. In fact, in January of 2020, the U.S. FDA issued a warning in a bulletin about patients developing ileus on clozapine. The reason constipation is such a problem is that clozapine is strongly anticholinergic. The average colonic transit time, or CTT, in normal adults is 24 hours. But on clozapine, patients have median colonic transit times of 110 hours. Once you treat these clozapine patients with maximal doses of each of the three common classes of laxatives, such as Docosate plus an osmotic plus a stimulant, even then the median colonic transit time remains elevated at 62 hours. Because the CTT, the colonic transit time, is so slow, you should not use bulk-forming laxatives containing psyllium in patients on clozapine to manage their constipation. The reason being is that the motility is so slow, the psyllium can exacerbate the problem because it sits in the colon and dries out. The technical term is it becomes inspissated. Well, what are the basic principles? Well, number one, clozapine is anticholinergic, so minimize other systemically acting anticholinergics. Well, here's the detailed approach to anticholinergic medications which the patient might be on and how to manage them. The strongly anticholinergic psychotropics are chlorpromazine, olanzapine, higher dose quetiapine, more than 600 milligrams per day, and tricyclics. These medications should be cross-tapered as clozapine is added with the goal of discontinuation in the first 4 to 6 weeks. The next class of strongly anticholinergic medications are the antiparkinsonian agents, benztropine, diphenhydramine, or trihexyphenidyl. Those agents should be tapered off during the first 2 to 4 weeks of clozapine titration. Lastly, don't forget about anticholinergic non-psychiatric medications. The bladder agents such as oxybutynin, tolterodine, and trospium, and if for some reason the patient is on glycopyrrolate, this should also be tapered off when clozapine is added. As we discussed, you may have to add it back at some point to manage the sialorrhea, but you really don't want it in place when you're starting clozapine therapy. And when you're starting clozapine, initially stop supplemental iron. Patients can often be off of iron for a number of weeks with no harm. Once they are on a stable dose of clozapine and the constipation problem is managed, iron can be restarted later. Emphasize to the patient the need to report if they have no bowel movement for more than 48 hours. And of course, encourage fluid intake and exercise. Caregivers should also be given the same information so they can help monitor to see if their loved one with clozapine treatment is starting to develop problems and not having bowel movements over 48 hours. Everyone starting clozapine should be routinely commenced on Docosate at a dose of 250 milligrams once a day or twice a day. The patient is on Docosate, you're titrating clozapine, they become constipated. What is the next step? Step 2 is to add an osmotic laxative. The two agents out there are either what's called PEG 3350 or polyethylene glycol 3350 or lactulose. PEG 3350 has better efficacy data overall for constipation, and this is the agent we prefer to use as step 2. If that combination is ineffective, now we go to the stimulants. Your choices of stimulant laxatives are either Senna or bisacodyl, and those will be added and pushed up to the daily maximum dose. There used to be an old concern that the use of stimulant laxatives would harm the muscular tone of the colon. This has proven not to be true. Add these as step 3. When a patient fails the combination of Docosate plus an osmotic plus a stimulant, The last step in constipation management of clozapine are using the newer secretagogues, which have been available now for a number of years. The reason being is that if you end up taking the patient off of clozapine, you often have nothing else to offer them to manage their treatment-resistant illness. There are 4 secretagogues which are available worldwide. And as some comments, which I'll give on all 4 of these, you should give it with food and water, and there are no drug interactions. So here's the 4 secretagogues which are available worldwide. The first one is lubiprostone. Its mechanism of action is a prostaglandin E1 analog. The starting dose is 8 micrograms BID. The maximum dose is 24 micrograms BID. The next one which became available is called linaclotide. This is a guanylate cyclase C agonist as its mechanism of action. The starting dose is 145 micrograms daily. The maximum dose is 290 micrograms daily. The only comment here is that it should be given more than 30 minutes before their first meal of the day. The next agent available in the US was called plecanatide. This is also a guanylate cyclase C agonist. The starting dose is 3 milligrams per day, and it's the only dose, 3 milligrams per day. Easy to use, give it a try. The last drug on the list is prucalopride. This has been available outside the US for more than a decade, and there are case reports of people using it in Australia and other places for clozapine-related constipation. Its mechanism is as a serotonin 4 agonist. The starting dose and the only dose out there is 2 milligrams. We have extensive experience at the California Department of State hospitals with lubiprostone and linaclotide. Anecdotally, we find linaclotide might be a bit more effective, and we've gravitated towards that as our preferred secretagogue. But most importantly, you must use these. Otherwise, you're going to end up having to take your patient off of clozapine, and that's not a good outcome. Often, when we start these secretagogues, they are so effective, we can actually remove some of the prior agents which have been added, such as the stimulant and the osmotic. And most importantly, at any step in this process, if the patient experiences severe abdominal pain or certainly feculent vomitus, this is an emergency and they need to go to the ER. The key point is that when treating constipation in patients on clozapine, bulk-forming agents containing psyllium must be avoided. Everyone gets started on docosate. After docosate, the next agents to add are an osmotic agent, and then in step 3, a stimulant. Lastly, if the other 3 medication combination fails, learn to use the secretagogues